To take this opportunity to welcome everybody to this webinar. So good morning, good evening, good day, wherever you are joining us from globally, because I know the invites have been sent out globally and we've had close to 100 registrants on this. So I think we are still waiting for participants to join. Given that October is Breast Cancer Awareness Month, we felt it befitting to host a lecture series on breast cancer as part of our ongoing efforts on a monthly basis, as part of the lecture series on cancer, to make academia, research participants, community groups aware of not just the research that is being done and the current knowledge that is coming to the fore, and the strides that we are making, but also the impact that our work is making and the translational implications of what we are doing. Because certainly as we move forward as a community working in this particular sphere, I think we've all come to realize that it's not a singular effort. And we require participation from all disciplines to work in a concerted effort to make a difference in terms of the increasing incidence of cancer. And having said this, leveraging the various programs nationally, globally that have been established, convening platforms, whether it's training platforms, whether it's educational platforms such as the lecture series, to strengthen the knowledge base, the scholarship around the cancer sciences, we feel is important as in ongoing efforts to not to lose touch with our patients, our advocates, that we are trying to make a difference, no matter how small some may consider it to be. There is ongoing engagement in every facet and every discipline of the breast cancer discipline that we are trying to engage with. Now, I don't want to bore you all with the numbers in terms of the incidence rates, etc., because I'm going to leave that to our professionals. But just to say that at the ACI, we remain committed. Bearing in mind the challenges that we face as a nation with the increasing epidemic, but also in the continent. And I think whether it's from a clinical perspective, whether it is from a diagnostic, whether it's from a psycho-oncology perspective, there are challenges at every path within the cancer continuum that are faced by both professionals like yourselves, but also the patients themselves. And how do we best address this is what the lecture series like this is best being used to try and understand, sum up, and mobilize our efforts going forward, because it is through these engagements that we better understand from everybody what the challenges are, because things continuously also change. And so that we at the ACI can also do our best to engage further and try to understand how best we can facilitate and help to move the agenda to address breast cancer issues on a more national and on a more continental level. So having said that, ladies and gentlemen, we've entitled our lecture series on breast cancer today, Cellular Transitions, Overcoming Clinical Challenges and its Psychosocial Impact, because as the name suggests, right through from the biological changes, right through to the impact that it makes on the patient is what today's webinar is all about. And having said that, we have three really remarkable speakers, and we have a really remarkable moderator who I'm going to introduce very briefly before I hand over to our first speaker. The first person that I want to introduce, just trying to get my slides going. So the first person that I would like to introduce in this webinar is Professor Marita Kotzer. Prof. Kotze, has really been a very passionate individual when it's come to cancer genetics. And I know she's devoted her entire career to looking at cancer genetics, transformations in cells, and how this leads to disease, and more specifically breast cancer. And of late, much of her efforts has been pioneering point of care testing, and particularly in terms of breast cancer. And much of her work recently has really been internationally recognized, and it's resulted in international awards. And I think it really it's synergistic, and it's really aligned to where a lot of the global efforts are are being channeled in terms of research translation, and what does the research mean for clinical decision making, and also for patient impact. And I think a lot of this work now, it's finding a way to the upper echelons in terms of diagnostics. So really, the work that Professor Marita Kotze is doing right now is really having an impact in terms of, from a clinical perspective, and also from a patient perspective. So we're really delighted to have one of the world experts based in our faculty that's really taking a lead role as a cancer geneticist. So Prof. Kotze, a hearty welcome from all of us at the ACI to this webinar. The second person that I would like to introduce is Dr. Jenny Edge. Dr. Edge, has really been a very passionate clinician, and I've come to know her since having joined. She joined the Faculty of Medicine and Health Sciences, and really a lot of her efforts, apart from being a surgeon, she dedicates a lot of her time and a lot of her own personal time in terms of training nurses. And she runs a very successful breast course for nurses, which we support at the ACI, and we will continue to do so. In training nurses about clinical breast exams, because we know that early detection plays a huge role, and she's really passionate about this. And she has also devoted a lot of her time, and I know a lot of her personal resources, to ensuring that apart from her clinical work in the faculty, a lot of her personal time is devoted to training, and so heading up the breast and endocrine clinic at Tygerberg and in the faculty, she still finds time to do a lot of this work in terms of her personal time. So and she's very experienced in this field. So we really welcome Dr. Jenny Edge today as well, to share her experiences and to share with us some of the challenges that as clinicians they face, and then what are the next steps that as an institution and also as a community that we've gathered here today, what we can do to try and minimize, mitigate, and assist to take these things forward, so that we can also help reduce some of the negative impact that these challenges are helping, or some of the challenges are preventing people like Dr. Jenny Edge from making the impact that they so really want to make from a patient perspective. And then Professor Ashraf Keji. Professor Keji, has focused of recent much of his work on the psycho-oncology aspects relating to breast cancer. And I mean, we know that from a patient care perspective and from a survivorship perspective, patients, well, not just with breast cancer, but cancer patients in general, are severely impacted upon by not just the news of cancer, but also from the effects of treatment and from the long-term effects of survivorship. And it's not just the patient that's affected, but also from the patient's families as well, and so forth. So Prof. Keji, who's a psychologist by training, and based in the Department of Psychology, will share with us his experiences from a research perspective, the impact, the psychological impact that breast cancer patients face in the community. Prof. Keji is also one of the board members of the African Cancer Institute. And then lastly, to welcome and to really say that we really delighted to also have Dr. Etienne Myberg, from the private sector, who's an oncology surgeon at the Mediclinic in Panorama, Cape Town. We always talk of private-public partnerships, but it's also been great to see Dr. Etienne Myburgh also publish together with Professor Kotze much on the genetics and the point-of-care diagnostics, and to see that how our private clinicians are also becoming involved as part of the research process to really make an impact as part of the clinical decision-making algorithms that we need so badly to develop our patient care pathways as well. So to Dr. Etienne Myburgh as well, welcome really from the ACI, and we look forward to your moderation of this session. So with that note, I want to just to say that the speakers would have about 20 minutes to deliver their presentation. And then following on that, there would be questions and discussions on the topic, and that would be moderated by Dr. Myburgh. I encourage you that during the presentations, if you have questions, to please put them on the chat, and those then can be put together, and then they could form part of the discussions as we move forward. It would be great to have some summary points at the end as to the possible next steps. Do we need more training programs? If so, in what areas? Do we need more research studies, more collaborative ventures? It would be great for us to know, so that at the ACI we would have a better idea as to what your barriers are, so that we could also make strides in assisting you do your job better and try to overcome those barriers. So having said that, I would like to then stop presenting my screen and then perhaps ask Professor Marita Kotze to begin with her presentation. Thank you very much
for the introduction. I'll just share my screen. Okay, can you see that? I'll just make it in slideshow.
We're able to see your screen.
It's full screen?
Yes, the full screen.
Thanks. I would just like to say again, thank you for the wonderful introduction, Prof. Suram. I always am amazed by the wording that you can use and how you can always make one feel very special. My presentation will focus on a BRCA point 1 and 2 gene point of care assay that we developed as an inventive step to help increase the access to precision medicine across the continuum of care in Africa. This was just the first slide. Okay, so what we can see here is that the article that we've been publishing very recently, we developed this assay that has these 4 wells, and this is where all the different probes comes together, and it is very important for us to develop these assays because the pathogenic variants in BRCA1 and 2, we all know that they increase the risk for cancer development, typically at a very early age, and that the BRCA1 and 2 status can inform timely decisions about preventive measures such as chemoprevention or undergoing prophylactic surgery to reduce the risk of cancer and overall mortality. Now, this is also now becoming very important for patients that may be eligible for PARP inhibitors. So it now makes BRCA1 and 2 genes also a target for treatment, which is a very exciting development for us as scientists and as geneticists, because now these genes that's been known for so long to be used in the context of familial risk and secondary cancers, risk of recurrence, they are now also very important in the pharmacogenomics field. So very important then is a fast turnaround time, because it would not be very helpful for a surgeon if the results of the test come out, after the surgery has already been done. So our concept is now looking very seriously into how can we combine point of care testing with genetic counseling, which is required for BRCA1 and 2 testing. So I was part of a group of about 38 African scientists all over the continent that developed a framework for implementation of genomic medicine in Africa. And you can see here, I basically wrote section 8, where the counseling was then positioned together with point of care testing as an entry-level assay. The informed consent was a very important process. One of my postdocs, Dr. Rispatoro Savi of Kenya, was instrumental in that work. And then we call it pathology-supported genetic testing because we really integrate the genetics with the tumor pathology, which is used by the clinicians to treat the patients. This is the driving force, is what is the pathology, and now the genetics could then take another step for further risk stratification and just bringing it down to a subset of patients that could benefit from precision medicine and individualized treatment. So we are now moving also from researchers to become part of the service delivery process as medical scientists, which is a very exciting time for us. I will just focus on the first two aspects in my talk. This is a platform that we currently develop with Medical Research Council's support for a grant. And we are very excited about all the collaborations to take the process from a little point of care test that can hopefully be done soon, very rapidly and very cost effectively across the continuum of care, and being able for us to also help by extending maybe across all the different platforms, panel testing to whole genome and whole exome sequencing in uninformative cases. So the whole process is where we now can risk stratify patients more effectively into those that would benefit from the BRCA point of care testing, and towards those that their cancers might be more lifestyle driven. So many of the cardiovascular risk factors that can be pathways involved in many NCDs, non-communicable diseases, the comorbidities like risk for osteoporosis in breast cancer patients. Sometimes that can be associated with a treatment like the aromatase inhibitors. And on the other hand, genes like CYP2D6, where tamoxifen metabolism pathways is also relevant to many NCDs, and that we can then use this test as a step towards that. And we can see how central the genetic counseling process is, all these different aspects that a genetic counselor can mitigate the risk of unnecessary testing and causing more anxiety than what the benefit could be for patients. So we all know that when Angelina Jolie told the whole world about her experience in her family, the high risk of these BRCA genes, and how she then takes the necessary steps to prevent cancer in her case to a large extent, that has really brought about a lot of attention onto genomics. So I think, if I think back about that, so many people contacted us about testing and should they be tested. And I remember at the time I had a grant with the Cancer Association of South Africa, and we developed basically a tick box or a check box that the Cancer Association loaded on their website so that people could quickly screen through and understand that when we do BRCA1 and 2 testing, the ideal is that there would already be a person in the family with the cancer so that you can identify the family-specific mutation and then screen other family members for either having a higher risk so that they can do preventative steps, take them, and on the other hand, those that may be negative, what can we do further? So this is really a journey starting around 2001, writing this article, my first article about genetic testing and breast cancer, how we could see from the service side how many people even carry a pathogenic variant but would not, even at a young age, by the time that we did the testing, did not show the clinical features like cancer. So this just opened up for me this whole new world of how do we, address all these concerns. And some people would rather opt for more regular surveillance and not maybe a prophylactic mastectomy, and that's their choice. So before we even started to, think about implementing this BRCA point of care assay that's developed based on several relatively common, what we call founder or recurrent variants in our South African population, we did a survey, and many questions was asked, and this was basically filled in by about 32 geneticists, genetic counselors, clinical geneticists, and others that attended the Human Genetics Conference in 2019. It was a pre-conference workshop, and you can see there that it's very detailed, but I've divided the questions up in benefit and risk. And you can see every time when we mention genetic counseling support, the agreement was very high for the benefit of this test. There was also some concerns raised, and we took all of this into consideration. And this is the article where Dr. Myburg was also involved in, that Prof. Sirum mentioned earlier, and he's also looked at this questionnaire and gave me some advice. So this is one of our genetic counselors who was really pioneering the process of combining point of care testing. You can see on this little apparatus here with genetic counseling, and so she is one of our previous PhD students. So she's a medical scientist, and she then went further and did a course at UCT for genetic counseling. The pioneering informed consent by RISPA from Kenya. You can also see how all of these processes, there's like you're building all these bricks into a building, and nothing is standing separately for me. So this is probably why I can make things very complex, but in my head they just all fit in a certain pattern. So if we then just go back to the point of care test, how it can be used as a screening step to decide if a person should proceed and extending to next generation sequencing. The most comprehensive is whole exome sequencing and whole genome sequencing. The problem with that is that we can uncover a lot of variants of uncertain clinical significance, but the same with gene-based testing to a lesser extent though. So we then developed this algorithm, which we hope that we could implement in future in South Africa and maybe in the rest of Africa and the world. We would need to look at three aspects: the familial risk, the therapy-related or induced risks in some cases, and then the lifestyle-related risks. How do we bring all of this together to the benefit of a patient? I remember when we could only do BRCA testing many years ago, it was always a concern of mine that the other 80 to 90% of patients testing negative for BRCA1 and 2, that we don't really have a lot to say to them, basically, like we cannot exclude that there is a familial cause for your cancer, but maybe in future we will have better tests. And I can say now that we do have better tests, and we've got more extensive tests, and working with the clinicians has been just amazing for me, because we can now bridge the clinical implementation gaps between the multi-gene or single gene testing towards doing a whole exome sequencing and whole genome sequencing as part of the research component that we can add to a genetic service. So on this slide, we can also see that the platform is very flexible. At this stage, when the article of the first article that I showed on the second slide, we only had 8 variants in this test. You can see all the different BRCA variants. The RS numbers, the last 3 digits of the RS numbers are used to identify which of those variants in the gene we detected. But then with the article where Dr. Myburg was also co-author, and with one of my PhD students from the NHLS in Bloemfontein, Dr. Jaco Westhuizen, he actually identified a new founder mutation. So now we could not just move forward and submit this assay for, hopefully for SAHPRA approval, the regulatory body in South Africa. We decided to first include the other founder mutation also. So now we have 9 founder mutations, including that new founder into the assay was done by also one of my long away PhD students, Armand Peters. He basically created a job for him by being able now to manufacture these kits in South Africa. So the next step was then to look at how common is this founder variant. The most common founder variant was at the position, nucleotide position 7934. It was a deletion of G. I think most people working with breast cancer patients and others like ovarian know that this is the most common one. So we actually identified that at a relatively high frequency in our South African population. So you can see here the sequence changes, and this is what us as geneticists like to look at to see that there's a specific change. This is the gold standard method, and the point of care assay was then basically validated against this to make sure that we get the right result. Now the question was, how do we proceed with bringing more patients maybe to the benefit? Because at the moment the testing is only done in patients with family history, early age of onset, the triple negative type of breast cancer. But in South Africa, the majority of patients are hormone positive. So on the one hand, we also did a lot of research on a multi-gene assay where Dr. Myburg, you can see his name coming up here all the time. He was absolutely instrumental in developing the rationale for using a very expensive test in South Africa. So the cost effectiveness testing was done earlier this year, published. And we then tried to see, is it possible for us to incorporate the BRCA point of care testing into this transcriptional gene profiling concept. So here we can see that the criteria for testing, as I mentioned, internationally, the BRCA test is one of those that's been approved by the NCCN. The MammaPrint test that we showed in the previous slide, basically the same, also approved by NCCN, as well as many other of these tests that can be used to decide on the usefulness of chemotherapy, yes or no. The luminal A type that I showed in the previous slide, we also need to do molecular subtyping where we use a test called Blueprint. Those would not qualify for for chemotherapy necessarily, depending on maybe some other things that doctors may want to take into account, while the luminal Bs would be eligible for that. But we do not currently include that the ER positive. So should we include them? That was the big question. Should we now include the estrogen or the hormone positive patients for breast cancer also for BRCA testing? Can we go so far as to say that this test could be of benefit of all breast cancers in South Africa? So this is how we then looked at this in the article by Wisters et al. That we mentioned earlier. It has been shown that one of those founder or recurrent variants, one was actually a recurrent variant based on the haplotype studies that we did in the paper. More than 70%, sorry, there's a percentage missing, of the patients actually had one of those founder variants. Now it justifies for us the use of such a rapid point of care assay to select patients eligible for next generation sequencing of the BRCA or other cancer susceptibility genes. If it's negative, if it's positive, then immediately the decision can be made. At this stage, since the test is new, we prioritize then for the specific variant that we detect in the point of care assay, that should be repeated by accredited laboratory. We had good experience both with the NHLS laboratory and with PathCare, where they could immediately confirm a mutation that we got during the pilot study, and immediately there could be an action for the patient under positive cases. So we also know that long-term survival of pathogenic BRCA2 specifically variant carriers with estrogen positive cancer, they are worse with relapses on the long run. And it means that we can identify among the ER positive patients, those BRCA2 positives that could be benefit from more personalized medicine and earlier intervention. We also found an excellent performance of the portable screening device, which is called ParaDNA, for targeted genotyping of these founder variants across different ethnic groups, which is cost effective and time effective as a first tier assay. For us then to unlock Africa's diverse gene pool, we think that timely surgical intervention, cascade testing in families, and gene-targeted therapy now possible with BRCA1 and 2 testing is a very good first step in the field of breast cancer and some other cancers like the ovarian cancer, even prostate cancer and pancreatic cancer has been approved for PARP inhibitors, so that's very important. And we want to then establish this platform that can extend from point of care testing with everything else in between, genetic counseling, until we then can use whole genome sequencing now available for the first time in South Africa to do exclusion testing. If we cannot find anything else, and we have maybe also used whole exome sequencing, whole genome sequencing, then we can identify maybe variants of uncertain clinical significance that we could at least classify as likely pathogenic, which then mean that they have about a 10% chance that we could be wrong. So it is not an easy task to do the variant classification of novel variants, and we found a lot of novel BRCA1 and 2 variants in our Kenyan study in Kenya, breast cancer patients. So it is important for us to now have access to this. So just in conclusion, if we can initiate germline DNA testing at the point of care early in the treatment planning process, it can increase the access to the most common pathogenic BRCA1/2 variants identified in South Africa. We also believe it can reduce loss to follow-up because we can then also screen family members. They can all come together and maybe screen them together on that point of care test that takes about 1 hour to perform. We have a 1 unit, so you can do 1 test at a time, or you can do 4 tests at a time in a screening unit, which would be very ideal for family members. Now, the ease of using a cheek swab or a saliva in future, currently we have mostly used extracted DNA from stored samples in the initial validation, can now be combined with genetic counseling. We have shown that it's feasible. A lot of training with other genetic counselors besides Nicole van der Merwe, who did this work first, would be very important, and I hope that we would be able to do that to facilitate then the application across ethnic groups and tumor subtypes, that these patients that's eligible for PARP inhibitors can then be identified early on, because we have already seen that when patients are referred for tumor sequencing, with sequencing of their tumors, that at a late stage they are identified with a BRCA mutation, which could have made a big difference if that was much earlier picked up. So I believe that sending patients or referring patients for transcriptional gene profiling early stage breast cancers, if we can combine the BRCA point of care with genetic counseling and with the tumor testing of many genes that look at the metastatic risk of that cancer that cannot be provided through BRCA genes. We must remember that these many different genes, we've got like 20,000 in our genome, and they've got specific functions. BRCA is unique in the sense that it provides information from familial risk to recurrence risk and as targets for treatment. So we can now locally manufacture these BRCA assays. It's inexpensive. And we hope that it can be used in all South African breast cancer patients, other cancers also, as we now hope to do more research in those groups. And we really would like to invite all clinicians interested to maybe help us to see how user-friendly these kits and machines and so on would be in your environment, and that it could use it irrespective of age, family history, tumor type, or a recurrent risk profile. So I just want to acknowledge then my team. The actual star is Lwando. He's the person that wrote that article. That he's the pioneer for BRCA testing. He did it for the first time in South Africa. He just go for it. I'm just so proud of him. And then this is Rispa from Kenya on the right-hand side. Then we've got Kelo Lebu on the left-hand side, and she's now doing a lot of work in the laboratory from point-of-care testing to whole genome sequencing analysis. Just amazing for me to see how these young scientists develop. And then Kathy Grant is the one that, also one of my previous PhD students. Thank you very much. Any questions? Would be happy to answer.
So thank you very much, Professor Kotzer, for that very, very enlightening talk. What we will do is we will try and keep any questions at the moment for the discussion at the end. In the meantime, I encourage those that are on this webinar to also use the chat box as an opportunity to also raise your questions in the interim. But for now, I'd like to welcome Dr. Jenny Edge to perhaps share her presentation and then commence with her talk. Thank you.
Thank you very much. Prof, can I just ask you to stop sharing your screen so I can share mine, please? Professor Kotzer, could I ask you just to stop sharing your screen so I can share mine, please?
I'm trying to stop share.
I think you just need to press the cross next door to the microphone.
If you can click off next to the microphone on your left, sorry, on the right, there's a little cross on your right next to the microphone. Yes, that's right.
Brilliant. Okay, so I am going to start with going to the other end of the spectrum, really, in many ways, and that is looking at the nitty-gritty in the clinic. I'm not going to talk at all about Marita's research, but I hope you'll find that it actually kind of weaves in with many of the problems we find. And this, being Pinktober, really sums up the issues that we have. We can't take from what happens in high-income countries, and indeed the private sector in this country, and translate it into our clinic. It doesn't work. And COVID has now completely bombed a lot of the plans that we had. And there's absolutely no doubt that it has made us rethink things in many ways. And the last 2 years have been years of great change. So what about our breast cancer patients? Where do they fit in? In high-income countries, and I'm sure in Etienne's practice, the majority of patients present with stage 0 or stage 1 disease. I've combined stage 0 disease with stage 1 in these two graphs because really we do not have that many people with just pure DCIS. I note that we have more patients in the metastatic group since we've been looking at the data prospectively, and I think that's probably because the staging is a little bit more accurate, that we've both got more stage 1s and stage 4s, whereas before they were kind of lumped together in stage 2 and 3. And so the sorry state of us seeing a lot of patients with locally advanced or metastatic breast cancer remains in our clinic. So what is the timeline from when a patient first notices a change to ends up starting treatment? And this is really what I'm going to talk about, is how can we get that timeline shorter? The Department of Health have drawn up very clear national breast health policy guidelines, and they say that from presenting to a primary clinic to initiating treatment, that timeline should be less than 60 days. Just to give you some idea of the challenges, I was up in Limpopo and up in the Northern Province, and there going from a primary healthcare clinic to a breast clinic and getting a biopsy result just to prove you have breast cancer can take up to 11 months. So there are many challenges. And here in the Western Cape and Gauteng and Durban and Bloemfontein, we are doing much better than the rest of the country. But for most of our patients, it's the rest of the country. And indeed, in clinic today, probably a third of my patients were from the Eastern Cape. So what happens when you first notice a change in the breast? And I think this graph shows the difference in how long it takes to seek medical advice. There's been a lot of very interesting research coming out of Brazil looking at the management of breast cancer, and you'll see that there, on average, it's 8 months from a patient first noticing a change in their breast to presenting to a medical facility. And that compares unfavourably with countries like France and indeed the UK, where the time is about 1 month. Why does that happen and how can we affect it? There are 2 studies that have come out of this country that give us a little insight as to what's going on. One is from KZN, from Shakala, and she showed that the average grade at school correlated to the size of the tumour, i.e. the more education you got, the more likely you were to arrive with a smaller tumour than if you left school at the age of 14. The probability of a tumour being stage 3 or 4 was noted to relate to the distance from the referral site. And it would be interesting for us to repeat this study. This was done in Gauteng at Chris Hani Baragwanath. But if we did, we would get a false number. Why? Because we have lots of patients from Khayelitsha, they have postcodes in Khayelitsha, and in fact, they come from the Eastern Cape. So why do patients come late? We asked some of our medical students as a project to talk to some patients and find out, and we did it as an informal study. It is unpublished data and won't be published. And not surprisingly, we found that transport was a major barrier. And after that, communication and knowledge, along with financial concerns and psychosocial support. There are issues in the hospital, and particularly when it comes to the fact that we can't say that we will see you at 8 o'clock in the morning or we will see you at 10 o'clock in the morning. And there are moves afoot in the hospital to actually do something about that. So what do we do about transport? Well, in Tygerberg, we are lucky we have a transport fund and we can use it for the patients who attend our clinic. And today, we actually refunded about 5 patients for their transport funds coming to the clinic. It's strictly only the patient. We don't refund for the relatives coming, and we go on the taxi fares from the postcode. So if you fly in with your private helicopter from Hermanus, you will get refunded exactly the same as the person who comes on the taxi. We have a fundraising event tomorrow. Please, if you are free tomorrow evening, please come and join. Pink Lady Apples are our main sponsors, and they have been phenomenal and fantastic. So I'd really like to thank them. The other person I'd like to thank is actually one of the admin people in our unit, Ralia, who actually processes all of the transport stuff. We have really totally changed this whole fund in the last few years, and she has really been at the forefront of doing that. It has been somewhat painful to get it a fully audited fund. So how do we compare with other places? This is a study from Uganda that was published actually earlier last year. And they said it's knowledge, attitude, belief and practice. And this was as a result of talking to healthcare workers and saying, why do we see people so late? And they said that cancer is a diagnosis that's associated with death, which we hear all the time. And they also noted health systems and policy constraints and structural factors, for example, poverty. And I'd just like to include this quote. I've always felt bad when I'm telling a patient that they presented late because what did I do to help them present early? What have we done? What has the health system done to help them present early? And really the focus of my talk is focusing on the very small things that we have done in the breast clinic to try and make it easier for somebody both to negotiate through the whole journey of having breast cancer and having their treatment and the presentation to start with. So once they get to a primary healthcare facility, the problem is that many of the nurses are untrained, and we know that. This is a study that came from Sudan that rocked a lot of boats at the time it was published, because it was really one of the first studies that showed unequivocal benefit to clinical breast examination. It's very easy to be rude and about the role of clinical breast examination, but remember the demographics I showed you earlier. We have virtually no patients who do not have palpable tumours unless they're referred from the private sector, and we do have a few of those. Apart from them, everybody comes with a palpable mass. Now, clearly, if you come with a mass that is 2 centimetres rather than 10 centimetres, your prognosis is going to be very different. So what they did was they took the 2 counters that actually referred to the hospital, and they trained volunteers over 5 days, not even healthcare workers. They screened 10,000 women, and they showed that in the unscreened population, they had 4 patients that presented with locally advanced invasive ductal carcinoma, but they had 17 women who were diagnosed with breast cancer in the screened population. And really what's very interesting is that actually 7 of those had pure DCIS. They had pure pre-cancer, showing the utility of clinical breast screening. There are a number of other trials, but obviously time doesn't permit me to go into them. So we run 2 courses at Stellenbosch University. This is the breast care course. It is the only accredited breast course for registered nurses anywhere in sub-Saharan Africa. It's only for registered nurses and professional nurses, and it's aimed at a sister running a breast clinic. So it is aimed at somebody who actually is involved with the logistics, with the referral patterns, and all the other sorts of issues. It's a 6-month course. A lot of it is online. There are practical sessions, and there's 1 week of theoretical lectures. The Breast Care for Nurses is a smaller organisation. It's a not-for-profit organisation that we founded 14 years ago, and that actually concentrates on educating nurses working in primary clinics. So this is from the first point of care. When you walk into a primary clinic, this is the breast course for nurses, and this is a 3-day course. And we actually combined our resources with the PEP, the perinatal education program, where the emphasis is on self-learning. So the book Breast Care is free online, and it is written for nurses whose second language, or certainly not their first language, is English, and it should be able to be read on the loo or on the bus. A lot of it is very simplistic, and it does need updating, so please don't write and tell me it needs updating. But time has been such that I haven't had time to update it in the last year or so. So overall we trained over 700 nurses. I'm happy to tell you, and not many people can boast this, say this book has been translated into East Timorese. It makes me immensely proud. Why? Because the course is being taught in East Timor. It's been taken up by the Royal College of Surgeons of Ireland. We've just done a very big project for South America with one of the American organisations. But we haven't been able to do any face-to-face courses since the beginning of COVID. So we have collaborated with the Department of Health, and the contents of the breast course for nurses has gone online. Personally, I don't think it is nearly as effective as doing 3-day courses, and I don't think it's a substitute for face-to-face discussion and teaching, but that's where we are. The breast care course is being run at Stellenbosch University. We have started a course, and that has been done as a collaboration between the breast course for nurses, the Department of Health, Stellenbosch University and PACAMISA, which brings me to one of my big themes, which is we need to collaborate, we need to talk, we need to know what other places are doing and institutions are doing, both nationally, locally and internationally. The Department of Health, this is the beginning of their 14-step course on women's sexual and reproductive health, of which breast is one section. So what about when they get to the breast clinic? How do they get referred to us? And this has been a battle that we've had, because until very recently it was entirely by phone. So we've set up our website, which is embryonic, but is somewhere to going where we are, and that is for the breast and endocrine clinic. And we have gone entirely to Vula referrals. So one of the points that we were very clear about was that we should have exactly the same criteria for seeing a patient at Tygerberg as Hruteskär. So if you look on the Vula referral for referral to either Tygerberg or Hruteskär, you'll see exactly the same criteria. And we talk to each other all the time. We had a joint journal club meeting 2 days ago, and it's very important that we're on the same page, because we want to make sure that patients are referred appropriately, that we don't get a whole mass of patients being seen at one hospital. It does cause problems. This is straight from the Department of Health's breast policy document, and it says that they should go first of all to a district referral or a breast clinic, and then that they should be divided into 3 groups: high suspicion of malignancy, intermediate, or low suspicion. In fact, with Vula, if we have a low suspicion of malignancy, we usually deal with the patient, actually get the person in the clinic to deal with the patient. We cannot cope with all the referrals. We used to manage about 450 patients a year in 2018, and that number is nearly 700. So in order to actually cope with, we have the same amount of resources, in fact, we have slightly less due to COVID, we actually have to work smarter in order to keep these patients going. And one of the things that we did was we said we are not able to see all these women with a low suspicion of a malignancy. We actually need to educate our partners in neighbouring clinics so they don't come through to us. And then there are regional breast clinics, which I'm going to talk about in a minute, and specialist breast units. Clearly, Tygerberg and Hruteskär are the specialist breast units. Worcester, Paarl, Ister River, Karlbremer and Kailicha would be regional breast units. The specialist breast units should have everyone you'd expect them to have. So what about when they actually come to the diagnostic phase? One of the things that we have instituted in the clinic are protocols. It takes between 3 to 6 weeks for us to get a CT scan. It takes a similar amount of time to get ejection fractions measured. It takes a similar amount of time to get bone scans. We have to be selective in who we're referring. So we stick to guidelines. These are international guidelines. It's very similar wherever you go, but there's no room for extras. We have to get it right the first time, because if you don't get it right, then there's yet another delay for this poor woman with her breast cancer. So we are quite clear about, for example, the staging for asymptomatic patients who come with newly diagnosed breast cancer, who, how, and what further imaging they require. But we have a basic protocol, and this is adhered to in all the hospitals. Paarl, Worcester and Kailicha and Karlbremer all have CT scans, meaning that we actually get them to do their own CT scans to take some of the burden from us. Then all patients with breast cancer are discussed at an MDT. And we traditionally have the idea that an MDT is made up of all the different specialists. But in fact, what COVID made us do was extend that enormously. And we now have a virtual meeting that starts at 9:30 tomorrow morning. And we will be joined by Ister River Hospital, by Paarl Hospital, by Kailicha, by Karlbremer and by Worcester. And the medical officers at those clinics refer those patients. What does it mean? It means I know exactly who's looking after the breast cancer patients in those hospitals. It means communication between us is freer and easy. It really, really benefits patients. It means patients who need to come and see us, come and see us. Those who can be managed there are managed there. And if they have chemotherapy, we assess all the patients. The patients in Kailicha, for example, that need a mammogram come through our breast clinic and have a mammogram, so we see them. But they don't have to keep on coming backwards and forwards to us with their CT scan. We can manage to do that through Kailicha. In terms of their treatment and starting their treatment, theatre waiting lines times are a problem anyway. Theatre waiting times in the face of COVID have become a real problem and a real mission, and we've really had to try and do something about it. So we have really spent a lot of time at the second level hospital. We've also got an electronic note booking system, and we book patients directly on there from Eerste River to Cellullar. Karl Bremer we book in a different way, and Parlam Worcester have their own booking systems. And we also have once again collaborated with another excellent not-for-profit organisation, Project Flamingo. So what about the short course in oncoplastic surgery techniques? I'm quite sure, I don't know how many surgeons are listening, but I know Etienne would certainly agree with me and say every single tumour excision should be done following oncoplastic principles. So if we are going to spend a lot of time asking our colleagues in Worcester and Paarl, Cellullar and Eerste River to do these operations, we also have to put time in to ensure that they're comfortable with what we consider to be standard oncoplastic principles. So we have run a couple of fully sponsored oncoplastic surgery techniques courses. Once again, it was cancelled due to COVID, but we hope to be running another one at the beginning of next year. And our target audience are surgeons working in general surgery in second level hospitals. So we show them some of the basic surgical plastic surgical techniques to actually help them, and we also try and teach them a lot of oncoplastic techniques to prevent them getting in a mess. We see all the patients who have locally advanced breast cancer and who've had primary therapy, systemic therapy, before they go back to the second level hospitals, because we don't want them having patients that actually are inoperable or difficult or require flaps. We try and keep those, well, we do keep them at Tygerberg if they are more complicated, and that way we maintain what we hope is a fair service for patients and for the general surgeons. We've spent time in Cellullar, and we've had a Sentimag probe given to us, which is used at Cellullar and Eerste River. They share one. This means that the surgeons there can do sentinel node biopsies. You can see me there actually doing one. And also in Worcester Hospital, they also have a Sentimag probe. This is the team in Eerste River Hospital with one of our registrars who I went with doing a sentinel node biopsy. Project Flamingo, we have done over 100 patients on the Saturday lists. The problem was that last year we didn't have enough nurses to do more Project Flamingo lists. At Friskeer, they seem to successfully do them during the week, a feat which we haven't yet managed to achieve at Tygerberg. So we do the Saturday lists, but as I say, our limiting factor is in fact the availability of sisters who can work at the weekends. So what about discharging the patient home? Once again, this picture, I think, shows some of the difference between the situation where we are discharging a patient home and where other centres will be sending their patients home to. And this is a rather, how shall I put it? I find it a very sobering slide to see that only 66% of households in South Africa actually have refuse removal. And only 83% have good, reasonable sanitation, electricity and drinking water. We have to remember this before we send a patient home the following day after surgery. It's difficult enough in a middle-class household with an income to cope with drains, but actually sending somebody home who's living by the side of the road with no running water back to that situation really is untenable. So I'm very proud to say that we have done our own study to see why patients drop out of chemotherapy, because we know that we've had a number of patients dropping out of chemotherapy. And I think Professor Kaji is probably going to talk more about the study that's just been done by Brigitte. I might just say she won the prize at Begosa, so I'm very proud of the fact she did. And the aim was to examine the barriers and facilitators of adherence to intravenous chemotherapy amongst breast cancer patients seen at Tygerberg Hospital. And she was doing it really largely from the perspectives of breast cancer patients. But once again, it was yet another study that was bombed by COVID. So the focus, she shifted her focus slightly to healthcare workers. She looked at the macro system, exosystem, mesosystem and microsystem. And when it came to barriers for adherence in the microsystem, she found much the same as our medical students did. Physical symptoms and forgetfulness, transport and finances. I don't know why this is jumping, sorry. The mesosystem, lack of social support, family responsibility, exosystem, and this was really from the healthcare workers working in the oncology department. So they stress the problem of lack of oncology trained staff. And she talked about traditional healers, which is interesting because I'm not sure that in the Western Cape, many of our patients see traditional healers before coming to see us. Certainly in the Eastern Cape and the patients that come from there, that is more of a feature. In terms of factors of facilitators of adherence, it's so important for us to know why does this person who has no money with all these other problems that they have actually manage to adhere to the chemo system. Self-motivation, support from healthcare workers, fee subsidy, and other cultural norms all contribute to facilitators of adherence. So my last two slides really are looking at the projects that we're doing at the moment, and I've put electronic notes in big letters at the top. It has been a real mission, but our patients are now, all of our new patients are entered onto electronic notes. It's both an electronic notes system and it is a data collection system. You can't use REDCap as electronic notes. So this has obviously been done through Stellenbosch University and it's entirely POPI Act compliant. It was designed by me and it was actually written by two of my son's friends. So it's a cost-effective, sensible way. We cannot afford the commercial versions of electronic notes, but it's given us a lot more information as we go. So other studies that we're doing, we're looking at our volunteers. How did they cope with the pandemic? We're looking at the influence a mastectomy has on a patient with locally advanced breast cancer, not, and this we're doing with the psychology, Department of Psychology, not on patients with early breast cancer, on the influence of mastectomy and the effect it has on body image. And to my knowledge, that's the first time somebody's looked at this in locally advanced breast cancer. We're looking at how we prepare patients for surgery. Again, that's another collaborative project that we're doing. And we're doing that with the medical students, saying, do we prepare you? What don't we tell you that you need to know before you come? Because if we understand that, perhaps we can ensure that more people stay in the system. The role of ejection fraction. Do we need to send all the patients we do for ejection fraction, and how many of those actually have chemotherapy and when we use it? We've looked at the use of glue in patients with locally advanced breast cancer, and that was with a view to sending them home early. And the project that we are having yet another meeting about tomorrow that's been quite problematic to introduce is one using technology, because we need technology in low middle income countries. You don't need it in England where it is. We need it here where it isn't. And Patient Knows Best is an organisation that allows patients to have copies of their own notes on their phones, and it's used throughout England. The problem is, in its present form, it's not really, I don't think, going to be usable by our patients. So we have a very trusty band of medical students looking at the implementation of the system as provided in the UK. And by the end of the year, we're hoping to have a transformed system so that we can use it in our setting where many patients don't have smartphones. We're doing quite a lot of projects with the pathology sector, and I haven't included anything that we've been discussing quite a lot with Marita, and I haven't included those. And then we're doing projects on looking at the effectiveness of our nurse education. Two exciting projects that we're looking at. One is a collaborative project with the Department of Genetics that's also with WITS and with Cambridge University. And another is a project to evaluate, once again, using technology to look at cancer risk stratification models in our population, because we think they're probably the same, but we actually don't know, and it's important for us to know. So from the whole of Tygerberg breast unit, I'd like to say thank you for this opportunity to share some of the things that we're up to.
Thank you very much. Okay, please go ahead, Dr. Etienne.
No, I finished.
Yeah, thank you, Jenny, for your really wonderful presentation. I think highlighting all the challenges we face, I think, with breast care. So I haven't noted any questions in the chat as of yet, so please, maybe just to remind everyone, if you do have questions or little comments, you can post them in the chat so that we can focus on those things, and then we'll keep all the questions until the end of all the presentations. I think next up is Professor Keiji from the Department of Psychology. I think this is a very neglected part of breast cancer care, and we look forward to your presentation.
Yes, thank you. Good afternoon, everybody. Is my presentation visible?
Yes, we can see it.
Okay, great. So what I'd like to do today is share with you some research findings from a few studies that we've been conducting. This is from the Department of Psychology at Stellenbosch University, where I work. And it has to do with the psychosocial aspects of breast cancer. Just a couple of general comments before I share with you our study findings. There are various factors that influence emotional well-being and psychosocial adjustment, including interpersonal characteristics, how patients prefer to receive information, the nature of their relationships with other people in their family and their partners, the level of spirituality, the communication between the medical provider and the patient, and the degree of distress related to physical symptoms. And risk factors for distress include younger age, pre-existing psychological problems, presence of support, and lower education levels. So just to say, when we refer to distress, we're referring to an unpleasant emotion, feeling, thought, condition, or behavior. And being distressed can affect the way in which people think and feel and act, and can make it hard to cope with the effects of having cancer. Major depressive disorder, there are various symptoms associated with this, and I want to bring into focus the difference between distress and a psychiatric or psychological condition of major depressive disorder, which involves depressed mood, diminished interest or pleasure, weight loss, slowing down of thought, reduction of physical movement, fatigue, loss of energy, feelings of worthlessness, suicidality, and difficulties in concentrating and thinking. And then generalized anxiety disorder, another psychological condition, which I think is important to think about as separate from emotional distress. Generalized anxiety involves excessive anxiety or worry, where the worry is challenging to control. There's edginess, restlessness, tiring. The person tires easily, experiences greater fatigue, difficulties in concentrating, irritability, and trouble sleeping. So let me share with you a study that we conducted a couple of years ago at the breast clinic at Tygerberg Hospital, where we recruited just over 200 patients, and we administered a few tests, a battery of instruments, including the CSD. This is the Center for Epidemiological Depression Scale, the Hopkins Symptom Checklist, which measures distress, and scales that assess social support and body change stress. And we also had some demographic variables as well. When it came to distress, we found a non-significant difference between the commonly used cut point on this measure that makes a determination about whether the distress scores are elevated or not. And the average, the mean in the among the participants was non-significantly different from the commonly used cut point. Just over a third scored in the elevated range on this Hopkins symptom checklist, a measure of distress, indicating that at least one third of the sample experienced clinically significant distress. With depressive symptoms, we measured this using the Center for Epidemiological Studies Depression Scale. And again, a non-significant difference between the mean score of our research participants, of our sample, and the commonly used cut point. Just over a third again scored in the elevated range, which indicates that for at least just over one third of our sample, symptoms of depression were clinically significant. So these are screening measures. They're not used to make a diagnosis, but in all likelihood, those persons who score in the elevated range, if we were to follow them up with a diagnostic interview, there's a high probability of their meeting the diagnostic criteria for major depressive disorder. So what predicts distress and depressive symptoms? This is by bivariate correlation matrix. This is the result of 2 regression models, and we entered the demographic variables, medical variables, and social variables. And here's what we found. Body change, stress, and perceived social support were significant predictors of psychological distress, and body change, stress, and perceived support were predictors of symptoms of depression, CSD scores. So clearly there are aspects of the breast cancer experience that account for and explain elevated scores among the participants. This is another study that we conducted to understand how patients cope who receive breast cancer care. You can see the other researchers, and this was a qualitative study. We interviewed 21 female breast cancer survivors who were in remission, and they had a whole range of different treatments. And we identified certain themes that we called reappraisal, acceptance, relinquishing control, and benefit finding. And what I'd like to do is take you through just some of the quotations that we identified. So the first theme, reappraisal, downward comparison. For some people, cancer is worse than mine. Positive self-talk, you take that chance and you start fighting that experience of cancer. Acceptance, I know it is part of my illness. I have to accept it all. Preparing for future challenges, I've got to learn to accept these things. Acceptance and spirituality. I ask the Lord for calmness because I don't want to walk around with hate. A third theme was relinquishing control. I felt I only have one boob, so what does it matter? My husband doesn't care anyway. This person was relinquishing control by essentially giving up on the physical presentation. Trust in God. Your faith must be strong. Everything is in God's hands. And Lord, I give my breast to you. This is from someone whose breast was removed. Benefit finding. So this is an interesting phenomenon. Spiritual growth. Cancer brought me closer to God. You become stronger because of it. Personal growth. I think it made me stronger. This is what one of the participants said. Altruism, wanting to do good for other people. I will hug that person. I will make them feel they are loved. This is to someone else who may have had cancer as well. Appreciation of life, taking it one day at a time. So those were some of the ways in which patients coped with the experience of cancer. Then we did a study which was recently accepted for publication in the Journal of Health Psychology, and they recruited 12 participants to identify the experience of recurrence. So the 3 overarching themes were illness appraisal, coping, and body image. Firstly, illness appraisal, being determined to survive. I must fight and stay positive. I will fight as long as there is breath in me. And then finding the value in the experience. There's a very big purpose that God is busy with. There's some overarching phenomenon that this patient feels part of. Lack of will to fight. A part of me thinks I can probably survive this, and another part of me thinks life has been so hard. I don't know if I have the strength to do this again. This is in the context of recurrence. Illness appraisal. Waiting to see what happens. I'm going to wait and see what the doctors say and all of that before I make any life-changing decisions. And then ways of coping. I think I'll be fine if God is there. I always go to the support group and participate in this fun walk. This is social support structures. You can see the importance of social support and religious support in this context. Body image. Change body image as a symbol to others. I'm still beautiful even if my breast has been removed. Although there were others who were not able to accept the post-operative body. There are women walking around with mastectomies who have accepted it. I cannot accept the body image following surgery. For some women, appearance was no longer a priority. This time, I don't care if I don't have breasts or not. If I was vain about my hair, I've learned not to be. So just a couple of conclusions regarding the data that we found on distress. It's necessary to attend to this. It is true that most of our participants in the quantitative study did not have scores on the Hopkins symptom checklist and the CESD that were in the elevated range, but at least a third of them did. And for those individuals, it is necessary to inquire about their psychosocial symptoms and to examine ways in which these can be managed. So manage stress, information about the breast condition and treatment options, social and family support, a supportive relationship with the medical team, and in certain cases, psychosocial counseling. Management of mental health conditions such as major depression or generalized anxiety requires referral to a mental health professional for psychotherapy and, where needed, psychotropic medication. There is a place for psychological support and to control symptoms of depression and anxiety. It's not the first port of call, but for some people this may be indicated. It is necessary to understand the various ways that persons with breast cancer cope with distress. And these methods can be varied and a continuous concern, and service users, patients have various ways of managing the distress related to recurrence. There is no one-size-fits-all approach to coping. As you can tell from our data, there was a whole range of different ways in which people express their ability to cope with their condition. People cope in different ways. In terms of future directions, there is a need for psychosocial care for persons receiving treatment for breast cancer. Many tertiary hospitals in South Africa do not have clear referral trajectories for mental health and psychosocial services, and it does need to be discussed. It does need to be a matter that is placed on the agenda. This state of affairs is part of a broader trend of neglecting mental health more generally. We call this the mental health gap, the gap between the number of people requiring mental health services and the number who actually receive them. In many countries, this gap is fairly large, including as well in high-income countries. So future research should be aimed at identifying cost-effective and evidence-informed ways of attending to the mental health and coping needs of breast cancer service users. Thank you. That's all I got.
Excellent. Thank you very much for a wonderful presentation. I think all three the speakers have really done an excellent job. I haven't just have a run here through the chat, and I must say I haven't seen any specific questions that have been raised. So I think I want to just again encourage anyone on the webinar to please post a question, or at least alert me to the fact that you want to ask a question, and I'll happily oblige. I see we have one person with a raised hand. I just see if I can, and I don't think I can unmute you. There we go. You're most welcome to ask your question.
I think that's me.
That's you. Yeah, I can't see the full name, unfortunately.
That's fine. So thank you, Dr. Myberg, and once again, thank you to Prof. KG and the other speakers. I think it's really been very enlightening to see the entire spectrum around breast cancer and what's going on in the discipline. My first question, perhaps to Professor Kotso, the whole issue around genetic testing and the advent of precision medicine is something that certainly we cannot shy away from. I mean, this is something that the world is looking into, and with all cancers. I mean, I spent the last 2 days in a liver cancer guidelines workshop where there's a big move to also doing something similar and doing genetic testing to try and look at patients that will really benefit from chemo. So this is something I think we cannot shy away from. So I just wanted to ask, the issue around chemotherapy has always been and still is, the issue around the patient outcomes around which the drugs have been marketed, and the two outcomes have always been in either overall survival or progression-free survival. And we know it's always been with patients with metastatic disease. It's with the drugs that are a phenomenal cost. It's sometimes been just a matter of a month or maybe a few months. But what's always been lacking in the literature that accompanies data around overall survival or progression-free survival has always been quality of life. And even the oncologists now are starting to argue the decisions that are being made by the FDA or other regulatory bodies in their approval. So I just want to know, with the advent of genetic testing, especially looking at discordant pairs, where from a clinical perspective, one is not sure whether a patient is likely to benefit from chemo, especially where there's a discordance from a clinical perspective and where genetics can play a role. How do you see this making the decision making from a clinical perspective more clearer in going forward? And do you see this becoming more and more predominant in the decision-making algorithm, especially from the MammaPrint? I mean, we know, like in the US, the MIND-ACT trial also produced, evidence about genetic testing as a basis for decision-making. So how do you see this progressing, not just maybe for breast cancer in this talk, but for cancer treatment as a whole, rather than treating everybody in the same way? We stratify patients that are more likely to benefit. Yeah, so I'll leave it there. Thank you.
Yeah, I think this is a very good question. I think it's something that we've been struggling with a long time, to the extent that until 2016 and from when the MIND-ACT trial was done, and then only from 2017, big medical schemes like Discovery started to reimburse patients for the testing. Before that, there was a lot of uncertainty on who should be screened. If we now take the MammaPrint as an example, but I can say that we have this PhD study that was published in 2013 for the first time, where we then already decided, and it was really Dr. Myburg that gave us guidance. I remember I went to him one day to his practice, and I said to him, Etienne, who should we screen? Because there are problems with us as scientists not always understanding the clinical context. So can you help me? And he then wrote basically a script, if I can put it like that. We must not screen, we must focus on the hormone positive patients. We should exclude the triple negatives because they can actually only get chemotherapy. And I remember we even included the low positive, HER2 positives. They also included, but at this stage, the medical schemes, they do not, they always would give the Herceptin. So that wasn't, we didn't actually follow that really, except for a few cases where there was a clinical indication that the test could help to give us more information. So I think Dr. Myburg is actually a person that could give you that information, because, as a scientist, we can just follow on from what the clinicians guide us towards. And I think this is where the algorithm idea was so brilliant, because it's not anymore about doing a genetic test only. It is not a standalone test. It is something that you have to include in the algorithm. And if I now think of MammaPrint, it is easy because it's more the result gives you a yes or no answer. And we've got good evidence now with the level 1A evidence from the MINDAC and long-term follow-up that followed after that. The evidence is just getting stronger. It's not getting weaker. And I think this is also very important for us because we know that the evidence is just what the next paper publishes. You know, as scientists, we can be very scared about that any work probably could be shown later on not to be true. And I must say that because of this collaborations with the clinicians, it is very unlikely that something like that would happen. When I think about other tests like sequencing the tumor of a patient to decide on the most appropriate targeted treatment of chemotherapy, I must say we are quite disappointed about, you know, if you look at the cost of those tests and, you know, the benefit that patients get, I think we also need to develop an algorithm for that. But at this stage, you know, many times the testing is requested in a way that a patient or a husband or a wife would say, I just want to do anything in my power to even just prolong, even if it's just for 6 months or a year. So that one is quite a difficult one. So I think, Etienne, we need to really make a team up and, you know, get everybody that's really interested in this, like people asking these questions, so that we can come up with a better solution. I hope that we can do those testing sooner in South Africa. There might even be a possibility that we could do the MammaPrint test in South Africa in future by doing the NGS sequencing on the RNA side. But the problem is that we need to do at least 15 or so tests at a time. And at the moment, we do not even refer, not even so many patients are referred per month for the MammaPrint. So it's not possible for us to batch them. So that's my answer.
I'm not sure if Jenny wants to add anything to the debate on this.
Not really, because most of what I would add would be from my private practice days rather than my current practice days, where we're looking at a different spectrum of tumours. Yeah.
I do think the dilemma is, so I think in this perspective, I do think there are some things that are already of value, even at the very base, like let's say in the private, in the public sector. So I think something like BRCA1 and 2 testing, founder gene testing, let's say a point of care test, if you could have a fairly rapid answer for a patient on that, and especially seeing that sort of more than 30% of patients in Jenny's clinic it presents at stage 3 disease, those patients are all going to have neoadjuvant therapy. We know the data is quite clear if you're looking at the PARP biology, for example, so they can't afford PARP inhibitors at this stage in the public sector, but certainly the use of platinums as part of the neoadjuvant regimen is not going to increase cost. It's very cheap. It's something that could be, and certainly we know that complete pathological responses, when you incorporate that in patients who have BRCA1 and 2 mutations, significantly improves the patient's outcome. So I think that's, it's a small thing that can already be implemented in policy to be used in a public setting. So I think, at different levels, different things should be available. I think in the broader sense, I'm not sure what the cost of, does anyone know what the cost of a adjuvant chemotherapy is in the public sector? I'm not sure what the exact cost would be for the chemo and the supportive drugs. I'm not sure if anyone has a figure in their head.
The figure that I've heard quoted is extremely low, and not one that I think really takes all the factors into consideration. So I'm not even going to repeat it.
Yeah, but I think, let's say in theory, if you did MammaPrint at a 30,000 Rand, a point, and you selected your patients that would already be advised to have adjuvant therapy, for example, it's taken ER/PR positive breast cancer, HER2 negative, and you have a patient that you would say this patient needs to have adjuvant chemotherapy. If you add MammaPrint to that, you will halve the amount of patients that will need chemotherapy. So that's going to decrease the burden in that group of patients. And if your cost of chemo and care and supportive drugs, so if the absolute direct costs, and we're not looking at even at sort of all knock-on effects. But if you had a cost factor of anything of 80,000 Rand or more, then that will actually generate a cost saving. So the saving in chemotherapy cost will pay for that MammaPrint test, even if you do that at full sort of euro rates. So again, it's an issue of really implementing things in a way that can save a segment of people and sort of reduce the burden of disease or the burden of healthcare for a segment of people in our system. So I think that the latest data we've published already sort of indicate that we could potentially do that for that group of patients. I think in the metastatic setting, I would be very hesitant. There are, unless, so even in private practice, I always say you first need to decide, can the patient afford a biological? Can they, will the patient afford a immunotherapy or, anti-HER2 therapy or whatever? And only if the answer is yes, then the question is, okay, can we do some sort of molecular testing to guide our first choice? The problem I often see is that that molecular testing is used sort of fourth, fifth, sixth line down into the metastatic treatment line. And the problem is you're losing your mutational load in your cancer has increased to such an extent that you don't have good targets that you can really use. So I think, again, if we look at HER2 positive patients, if we look at triple negative patients, if we look at BRCA1 and 2 positive patients, those are the ones that I really think it might be valuable to have molecular testing so that you can decide up front in the metastatic setting whether you should have immunotherapy as your first line or whether you should have anti-HER2 or /PARP inhibitors as your first line. And I think the data now, clearly shows if you use immunotherapy as second, third line in the metastatic setting, the value you gain from that is really low in breast cancer. So if you want to use that, you need to use it very early on. And if you want to then use a PARP inhibitor, whether you use it first line or second line or third line, you still get the same benefit. So I think there's a value to have a little packet that you can say, okay, right, listen, for this group of patients, we'll use a profile that really targets those important things that we have good targets for. And I think the data, let's say PARP inhibitors, for example, I think your issue about quality of life is really important. So, although the overall survival is not prolonged significantly in the use of PARP inhibitors, and if you look at sort of months of progression-free survival, it doesn't seem that much. It sort of, gives you about 8 months or so, but it adds 2 years of symptom-free breast cancer progression, where if you don't use it, the patient develops symptoms of their metastatic disease 2 years earlier. So I think, again, quality of life maintenance for those patients is much higher or bigger than really the figure of progression-free survival. So I think there are situations that we should really be using molecular profiling to guide us. The problem at this stage is the environment is so diverse. Everybody just does what they want. There's no collaboration, no sort of consensus about what we should be doing. I see Jenny has her hand up.
Yeah, thank you, Etienne. I mean, I think it's a very interesting debate. The reality is that the way the funding, and you're welcome to criticise it, but I have come across this many occasions, the way the funding's done in the public health service is that each MammaPrint would be seen as an additional cost. It's not seen as cost saving. Making that argument just doesn't wash. I've tried it with many other things. We've tried it with introducing other things and saying, well, it saves an amount of time the patient's in the ward, we should do this. And they've said, yeah, but if that patient's not in the bed, another patient will be. The cost is the same to us, and that is it's a very different funding model from the private sector, and not one that I can easily use. So each patient who is sent for a MammaPrint would be seen as an additional cost. If I was given that money, I would use it for the adjuvant use of Herceptin. As you know, it's an absolute outrage, and you've heard me say this time and time again, that the National Breast Health Policy says that it is a breast cancer patient's right to receive Herceptin, and it's only in the Western Cape that we do not have access to that. We do not have capecitabine. We do not have goserelin. We should be having those drugs, in my opinion, before we go any further. So if I was going to be given more for the oncology budget, it would be focused there. Many of our patients are in fact sent for in vitro testing, as you know. A high proportion, and I should have actually got the number from our new electronic notes where I can go find out this information, are sent for BRCA testing. And it's, I mean, roughly in my mind, I would say it's about 30%. So, and literally that's going to be well over half of those who actually go for primary chemotherapy. So it's not as if we're not testing all of them. It's not as if we're not getting many of the benefits, but the benefits you can get from doing these types of tests, we can't get because we don't have the drugs. So, I mean, you know, if we can't even do something about our HER-positive patients, we are in a different starting block. And I do start every year, you know, with my proposal. And there is one person in the audience here who'll know exactly who she is, who I'm trying to persuade to do a project looking at that. And I hope her ears are burning, but I won't call her out. Thank you.
No, I agree. I mean, I understand that fully. And as you say, the problem in the public sector is that they've sort of got a fixed, you know, budget and a fixed expenditure. So whether the only thing is that opportunity cost of having X amount, you know, fewer patients that are filling the chairs for chemotherapy for breast cancer, which they can theoretically use for something else. But I mean, yeah, we can have a long discussion about that. I think you know, and I maybe to add to Jenny's, the thing is, once you start incorporating things, I know this, you know, government have got genetic counselling, but once you want to do point of care counselling, I think Marita can, you know, the importance of then having immediate genetic counselling available for that session is really important. So I think that is a critical thing. So yeah. Any other questions?
Just to interrupt, we actually do have that. We have, you know, a very good service from our genetic counsellors. There is another person with their hand up, by the way, just for your interest.
It was participant bio done.
Okay, maybe I can't see all the participants, so maybe you can unmute for us, and then that person can ask the question.
Thank you very much. My question is taking us back to the psychosocial part of the presentation. I would like to find out, has there been any studies about caregivers for breast cancer patients? You know, because in terms of mental health effects of the cancer, it's not just on patients alone. Even the caregivers also experience some sort of worry, anxiety, and you know, it can be depressing seeing your loved one going through a particularly tiring, rigorous phase of life. So, has there been studies on effects of mental illness or psychosocial effects of mental illness on caregivers as translated to management of patients? Because you know, these caregivers are the ones who do the running around, who do the financing and some other things. So is there any study showing how the effects of having mental illness or psychological impact of having your loved one having a cancer on the eventual outcome of treatment and prognosis on the patients themselves? That's my question. Thank you.
I guess that question is for me.
I think, yeah, you should answer that. Yes.
Yes.
All right. So there are many studies on caregivers' experiences, including caregiver coping and burnout. We are in our group. We haven't done any of those studies, but in the international literature, there's considerable research on caregivers, not only for cancer patients, but for people with a range of other conditions, including HIV, etc. The thing that affects low and middle income countries, of course, is the financial cost to the household of having a patient with a serious medical condition, which is another factor that affects caregivers as well. So yeah, I mean, a quick literature review will yield several studies on this topic.
Yeah, I can maybe just, there's actually a published meta-analysis that looked at the outcome of breast cancer patients. We had a recent discussion about this, looking at psychological support that's being given to patients and their outcome. I think there's something like 37 studies that have looked at that have been included. So these are obviously both from trained psychologists versus, let's say, sort of therapists. But I think the bottom line of those studies are that there's definitely a survival advantage when patients have good psychological support. I'll put a link to that publication in the chat for you so that you can find that. Jenny, you want to add something?
I want to say two things. First of all, thank you so much for bringing this point up, because breast cancer is a disease of the family. It is not just a disease of a woman. And for many families, the woman is in the center of the family. May or not be as the primary wage earner, provider of money, because we know in this country there's a disproportionate of single women households. So for many cases, she is actually the primary financial person as well. The second point is that partners really matter, and for most of in most women's cases, those are male partners. So men really matter, and trying to get men to come around to actually share responsibility and understand their role, and even actually become part of the solution. And so today I had a long conversation with a couple in which he referred to her problem and that she must sort her idea about her body image out. Well, you know what I said to the patient, you can guess what I've said from the patient from what I've just said. So partners really do matter. And as I say, there are, I mean, obviously in single sex relationships, the dynamics are slightly different, but actually overall they're much the same.
Can I add to that, please?
Yeah, sure.
I think this is a really interesting discussion, a very important discussion about the role of partners and the role of men, and how masculinity is constructed, the way in which men conceptualize themselves as supporters or support givers of women with a serious health condition. So, I mean, I think this is a really important area that requires some research, because there are cultural aspects of constructions of masculinity that will go into the way in which men think of themselves as involved in supporting women with breast cancer.
Yeah, I think from my side, if I can, Jenny, as far as I'm aware, certainly when I was at Tygerberg, there were never a psychologist or a therapist involved in the breast clinic. I'm not sure if that's changed at all.
So until COVID, we actually did have a counsellor, and we have a counselling room, and she was a volunteer. Obviously, we are and we also had a lot of volunteer people, and we had another volunteer psychologist as well. So we were reasonably well off actually before COVID, but since COVID, things haven't been great. When we have somebody who really needs a lot of help, then we will always find help from a clinical psychologist, and the Department of Psychiatry are really helpful. But for the general discussion group, which most women need, they need somebody to offload to talk to, or anything else. We have got a bit of a hole at the moment, although our social work department is actually also very good as well.
Yeah, so I think I've again in the chat group, for the psychologists and therapists out there, I've actually sort of pasted the guidelines from the British Psychology Society for the role of the practitioner psychologist and it has a little bit to do with women having breast sort of risk reduction breast surgery, but it does sort of overlap with breast cancer as well. I think it's a very good document that I think if you're a psychologist that works in that field of oncology support, then I think that's an important thing. And I think the other thing that I want to sort of pop in the chat is sort of a recent, very interesting publication that looked at sort of specific, I think the whole issue of mindfulness. So the problem is we talk about support from family members and husbands and whatever, but I think the issue is we need to empower those people. And so people think about psychology, and I think there's a big stigma about that in society in South Africa. And I think the issue is we need to empower those people to say they are actually sort of skill sets that we can help you with, that you can use that will make your life better. So I think there's a publication I'll put in the chat as well that look like, it's a form of mindfulness therapy, but actually has shown to really be beneficial to patients getting chemotherapy, for example. And it's something that's fairly easy to teach. It's something that you can do over an app or a phone call. So you don't need to have necessarily a trained psychologist. So I think, we need to, even in private practice, we need to really start thinking a bit differently. So the issue is we need to start thinking out of the box. And I think the psychosocial support that patients need, I think this is really important. So yeah, thank you very much for that. There are 2 hands that are raised. Maybe we can unmute one of those.
I just have a quick point related to what Dr. Jenny was saying about the volunteer counselors and psychologists. I think this is very good, and by all means we need volunteers to do this work. But I wouldn't only want to say that volunteers are to be resorted to. We do need professional people to be integrated into the care team, so that the patients who require psychosocial services are in receipt of services that are evidence informed by trained professionals, and volunteers should be supervised and supported with ongoing training and ongoing supervision, so that we can ensure that that patients get the best possible care that is informed by research and provided with the highest level of professional ethics, I guess.
Professor Surab?
Thank you, Prof. They are both trained. They're both qualified people. They're not volunteers off the street.
Thank you. Dr. Edge, you've mentioned succinctly about the disparities in terms of, obviously, in terms of the timelines between private and public sector, and also the stage of disease. And so I was wondering, what about your views on the thoughts of our primary care physicians out there in the public sector, in our clinics, do you think that there needs to be a continuous sort of educational campaign apart from just our primary care nurses? Do you think that our primary care physicians as well need to be educated further in terms of timely referral, or how to recognize symptoms, and so that patients get into the system much quicker, followed up more timeously? What are your thoughts on that in terms of the primary care role?
No, thank you so much for asking. In the project that we were doing in Khayelitsha, along with the breast nurses training, one of the points that we were actually trying to do was actually bring the primary care physicians in as well, because the nurses were saying, we recognise that there's a problem, we send the woman away and then she doesn't come back, and there are only certain doctors that do core biopsies, for example. So one of the things that we've done, again, it was actually started by Francois Malherbe from Hirscheskeer, but I have sort of basically taken a lot of his course and taught it with him on a number of occasions, to actually train doctors, primary care doctors, to do core biopsies, because we are beyond the age of doing FNAs and waiting for a result and getting them done. So what we did in Khayelitsha was say, if there's a woman with a breast problem, at any time working within that clinic, there should be a primary healthcare doctor who can do a core biopsy, because we're not talking about little bits of sand for most of these women. Sure, the iffy ones can be referred through the system, but somebody who comes in with a mass, you should be able to do a core biopsy of that mass. And if they require a core biopsy, they should not go back to the clinic. Their next point of call should be the Khayelitsha Breast Clinic. So we've tried to use both referral pathways and by increasing knowledge, and that came directly from talking to the nurses, and the doctors were really on board with it, and we had about 15 of them who came, and there was one from each clinic, and the idea was, along with the nurse training, to actually run that in parallel. And we invite the doctors to the last day of the nurse training so that we can discuss a whole lot of topics. So yes, we definitely are inviting them. We invite them to be part of the breast nurse training, because we see it as going together. But certainly doctors need to know who to biopsy, how to biopsy, and we must offer them a slick and efficient referral pathway so that that patient isn't going backwards and forwards with inadequate biopsies.
Thank you.
If I can, so I'm not sure, I don't see any other hands raised, and I don't see questions. Any, Jenny, I know that that study you quoted from Sudan, they in fact used community volunteer, women community volunteers that would go house to house and actually do manual breast exam. Do you think that, you know, that's something that we should, you know, I mean, I'm a critic of implementing, you know, mammogram screening in a country like South Africa, but I think my question is, you know, what about something like that, where we could actually be training volunteer women to be sort of health advocates and do screening? Do you think it's an option that we could try?
We can try it, but we haven't, for exactly the point that Professor Kaji was saying of having untrained people and who are kind of unmonitored. And so that was done as a specific study to prove the point. But I think that I totally agree that you actually have to have a bar, you have to know what's going on. And so, you know, starting with the nurses seems to me to make an awful lot more sense rather than a volunteer. We have an awful lot of work to do in this country just in the clinics. So that's where we put our emphasis. There's nothing wrong with what they did. It's just that it requires a lot more supervision and a lot more micromanagement. And in the end, isn't going to. So one of the studies we're doing is not to see how much the nurse benefits from the training, but to see how much the clinic benefits from the training. So the PEP principle is that the nurses should be doing self-education through the books and things. So the idea would be that you have one of them that comes on the course, but it should change the attitude within the whole clinic.
But that largely relies on opportunistic screening. So I'm sort of more talking from a policy point of view to say, you know, if we want to really reduce the burden of disease, the only way to do that is to, you know, you want to raise awareness. And you want to pick things up earlier. So
absolutely. So one of the things that we did was we used a risk calculator, because if you do opportunistic screening, what happens is you have all of the 20-year-olds and 30-year-olds with the aching breasts at the front, and you have the older tonnies that you actually want to examine right at the back. Why do you want to examine the older tonnies? First of all, because they're the ones who have the breast cancer. Secondly, because their breasts are much easier to examine. And so it makes much more sense to put your resources into that. So a project that we did in one of the clothing factories was using one of the risk calculators and only taking people who have an increased risk of breast cancer and actually stratifying them according to we actually use the IBIS risk calculator rather than the CanRisk. It was before the CanRisk one was modified, and only if they had a greater than 1% risk, which meant anybody over 40, in the next 10 years did we actually offer them clinical screening. So I think stratified risk screening makes an awful lot more sense if you're going to do that. That gets quite complex. Certainly we wanted to do it in the for the sisters working in the hospital, but again it's been rather blown apart. But it's extremely labour intensive, and you know, we have enough just dealing with where we are rather than actually trying to make an imperfect system, you know, trying to do something. So that's why we've gone in the direction we have.
Do we have any other comments or contributions from the audience? So I think then from my side, I think I want to maybe just, thank the speakers to say, I think this is Breast Cancer Month is always, to me, it's a little bit, it's a good month, but then I know that, from this week until the end of November, it's going to be crazy. So it's sort of a, love-hate relationship I have with it. But I think I want to say thank you very much to Professor Marita Kotze, someone I've worked with and known for a long time, for her passion and really trying. I think it's difficult in a country like South Africa where we, like Jenny said, where we have these challenges that are so sort of basic to think about, doing genetics on patients. So it's almost like this sort of, NASA in the middle of Africa type of idea. But I do think that for me, the thing is, how can we implement that? And I understand the policy struggles and the funding struggles and whatever that Jenny noted. But I do think I still have this dream that we can really do better and treat patients more appropriately by using things like this, and a lot of those things have become much more affordable. So I think that's the first thing. From Jenny's side, thank you, Jenny. I think it was a wonderful overview of sort of the big challenges that we face. I think it is disconcerting, to say the least, that we have such a huge burden of patients presenting in late stage of disease. I think the work that you've done to try and see where we can sort of streamline things, I think the Western Cape is playing a big role. It's a little bit worrisome that we're not seeing things improving a lot in the Western Cape. And if you look at the data that was published from the BRICS countries, South Africa, if China, Brazil, India, South Africa's mortality rate for breast cancer in the public sector is still sort of almost the worst of all of those. So I think I do feel that we need to start, intervening earlier in this whole pathway. I think that getting patients to referral is excellent. I think the referral pathway has become much more defined. I think it needs to be publicized a little bit more. A lot of patients are being cared for by private healthcare practitioners, and I still get lots of phone calls. Fortunately, I can guide them into how to refer the patient. So I think that's an important thing. So yeah. And then from the psychology point of view, I think it is a very neglected problem. I think the data that was presented is it's wonderful to see that there's some interest that's started, that we're starting to quantify a little bit what the effect of breast cancer is on patients. I think that the next step obviously is to see sort of how can we address that, how can we implement policies that are really, as you say, evidence-based, to be able to deal with those patients. So I think the first step obviously is evaluating patients for mental illness, evaluating patients that have significant distress and depression associated with it, and being able to sort of refer those patients to more professional treatment. But I think the next step really is, for me, is to say, how do we provide psychological support to those patients in a much more organized manner? So, at the moment, we've got social workers that do support. We have some sort of volunteer support. Those people are trained people, but the bottom line is the demand out there is huge. And I think the data clearly shows if you give good psychological support, patients' adherence to chemotherapy is better, their survival is better. In principle, they do better. So I think it is a very important part that we should be expanding, and I really want to commend the research from the Department of Psychology, and I hope that we will see more and more of that. I think that's sort of a summary from my side. I think Prof. Suram, you want to maybe say the last word?
Thank you very much, Dr. Maiwood. I think you very succinctly summarized what our speakers have mentioned today, and the summary of our discussions are quite clear that this still remains a multifaceted, complex problem, but it's clear that we have individuals that are very committed to dealing with this, and I think that we need to just continue to persevere. So, we at the ACI, we also remain committed to helping, to understand the complexities from both the clinician perspective, the researcher perspective, the patient perspective, so that we can try and bring resources and to try and help, to try and alleviate some of the burden and try and provide some of the support that is required. And we will continue to do that in whatever way we can. So beyond that, all that's left for me to also echo what you have also said by just thanking all the speakers and all the registrants and participants on this call. And we look forward to future engagements on this topic, and also in the future lecture series on cancer that we have coming up in the months ahead.